Hello, everyone. Hope everyone is doing well, and thank you for joining us at the EPIC conference today. My name is Bryan Hong, and I'm an assistant professor in the Department of Psychology in the Neuroscience and Applied Cognitive Science area at the University of Guelph. And I'm really excited to be here today chairing this fourth session of the EPIC conference in the Cognitive Health and Dementia Challenge area. So just before we begin today's session, I'd like to note a few pieces of housekeeping. So first, the EPIC conference sessions are going to continue to take place on Zoom between 12 and 1 p.m. Eastern Time on Friday this week, and then also on Monday to Thursday next week as well. And I really encourage you to attend all of the sessions and check out all of the Age Well EPIC conference webpage to download the EPIC conference program, and that includes details on each of the different sessions, or you can also watch a previous recording if you had missed anything as well. So in terms of today, what we're going to do is I'm going to begin today's session with a really short presentation just to give a brief little primer on the Cognitive Health and Dementia Challenge area. And then we're going to have a series of great presentations. We're going to have two research presentations followed by a 5-minute Q&A following each presenter. And then we're going to have a moving the dial presentation as well, which features a supported startup. And then finally, we're going to close the session with a more general Q&A where all the panelists can also chat as well. So in terms of the presenters today, we're going to have 3 presentations. I'm excited to introduce Joy Lai and David Black, who's going to present beyond participation with experienced advisors in dementia research. Secondly, we're going to have Zoe Gilson and Sam Liu, who's going to present patient and industry partner collaboration and development and optimization of MindMover. And then finally, we're going to have Annika Moon, who's going to highlight how Living Safe is moving the dial by improving quality of life for Canada's older adults and caregivers. So as you're going out the presentations, you might have lots of questions as well. So I encourage all the attendees to use the Q&A box to ask questions. So if you look at the little taskbar at the bottom, there should be a Q&A section, and then I'll also monitor as we go along. You can leave a comment on a question as well and upvote questions that others have submitted, so then it will get prioritized. And then I also welcome you to use the chat as well. Today's session is also going to be recorded and it's going to be available for playback. And then links to playback are going to be posted again on the EPIC conference webpage, and then also the AgeWell YouTube channel. And then if you choose, you can also enable closed captions today for Zoom on the Zoom toolbar at the bottom. So you can get access to that. Okay, and I think that those are all of the pieces of housekeeping that I have. So without further ado, what I'm going to do is I'm going to share my screen, and then I'll just give a little brief short introduction to the challenge area, and then we can jump into our presentation. So let me quickly share my screen here. And here we go. Okay, so again, I'm excited here to be welcoming you to this challenge area about cognitive health and dementia. Again, I'm currently an assistant professor at the University of Guelph in the Department of Psychology, and my main research interests are in memory and aging. So I'm really excited to be hearing all the talks that we have here today. This is likely not news to folks in this audience, but you probably all know that Canada is currently experiencing this rapid shift in its aging demographic. So previously, when I've used statistics like this, there were projections to the early 2030s, maybe even a bit longer than that. But I recently just checked, and even by this year, Canada is poised to become a super aged country. So what that means is that 1 in 5 individuals are going to be over the age of 65. So currently, that's just over 8.1 million Canadians currently. Of course, this is not a situation that's unique to Canada as well, and is occurring amidst a similar pattern worldwide. And the United Nations actually declared this to be the decade of healthy aging. So they're supporting a lot of work internationally to help support people not just to live longer, but also healthier lives as well. So this is a really exciting area of research to be in. Now, in terms of my own research, one of the most salient changes that we see with aging are these changes in cognition. And naturally, this stems from the changes that we see in the brain as we age. So just like other changes that you might observe in your body, you might see like your hair turning gray, or you might start noticing changes in your physical as well. The brain is also going to experience changes as well. So just as a little bit of a brief example of this, on the graph on the right, this is showing age in years, and you can see these ebbs and flows in the brain as we're aging. Right? So we see changes in gray matter volume, we see changes in white matter connectivity between different areas in the brain, we see changes in the neurochemistry as well. And all of these are linked to changes that we might see in our cognition as well. So as we age, we might notice changes in things like perception, attention, memory. And oftentimes we think of these as declines, but there are also many other changes as well. So for example, in aging, we also see improvements in things like semantic memory, our knowledge about the world, things like positive emotional regulation, and so on. Again, minor changes in cognition are expected with aging. So if you notice that you might start to forget names more frequently, or forget where you put things, where you place them last more frequently, that's completely okay. But naturally, many individuals report these changes in cognition, and particularly dementia is one of their biggest worries with aging. The good news here is that there's actually a lot that can be done to help promote healthy cognitive aging for older adults as well. So this is a figure from the most recent report from the Lancet Commission on Dementia in 2024. So the first Lancet report was about 2017, so just under 10 years ago. So they've been doing quite a lot of work just to identify these different risk factors that might be associated with dementia. And one of the lenses that they're taking or adopting primarily is this more prevention-focused lens. So in this report, they highlighted how up to 45% of cases of dementia might be prevented or delayed by modifiable lifestyle factors. So this includes a whole host of different things that might be addressable, such as hearing and vision loss, physical inactivity, social isolation, and diet, and so on. In addition, in the report, they also highlight a lot of efforts to help support both early diagnosis as well, so you can detect the changes in cognition that might lead you to kind of have kind of like a check-in with your physician, for example. So improving awareness, better identifying symptoms, and so on. And in addition, they're also identifying work to better support person-centered care, both for those who are living with dementia and for caregivers as well. And why I find this particularly exciting is because they highlight the potential role of technologies to support this, which is why it's so cool to see all the research that's being done across Canada in the Age Well Network. Oftentimes, there's this misconception that older adults are unable or unwilling to use these technologies, but really this is not the case. So for example, a recent survey from the Center of Aging and Brain Health Innovation, or CABI in Toronto, they did a recent survey of Canadians over the age of 50 from across the country. And what they found was that older adults had a really high tech adoption. So they reported that 100% of the respondents had owned a smartphone and 99% were using it daily, and that there was this real interest in technologies to support things like brain health, reduce dementia risk, and maintain independence. And I found this quote to be particularly compelling as well, because even for folks who might feel like themselves are less technologically inclined, there's this real interest as shown by this quote here. They really want to stay in touch with others, learn about things, and kind of exercise their brain as well. So without further ado, I really wanted to bring us to these talks today, which highlight some of this really cool work using technology to support cognitive health and dementia in older adults. So I'm really excited to hear about all these exciting talks over here. Again, we have 3 talks by Joy Light and David Black, Zoe Gilson and Sam Liu, and then Annika Moon today. Okay, so with that, I am going to bring Joy Light and David Black to the stage. Let me end my slideshow. Oops. Where's my Zoom? Here we go, stop share. Okay. All right, so we'll turn it over to the first presentation. So Joylai is a Master of Applied Science student at the University of Toronto's Institute of Biomedical Engineering, and she's supervised by Dr. Alex Michaelides. And her research really focuses on developing these machine learning models for anomaly detection in assistive technologies, specifically aimed at supporting people living with dementia and their caregivers. She's working to improve digital reminder systems by incorporating personalized behavior tracking and early warning systems for safety concerns, and her broader interests include exploring the use of machine learning in rural healthcare settings and ensuring that AI systems are developed with ethical considerations in mind. We also have David Black, who was the caregiver for 17 years for his mother, who was diagnosed with vascular dementia. He's a strong advocate for aging in place and has considerable experience setting up, maintaining, and adapting this form of care. In 2021, he joined the Maritime SPOR, or the Strategy for Patient-Oriented Research Support Unit, where he completed his patient partner training. And in 2023, he was a member of the University of New Brunswick St. John Center for Research in Integrated Care's Dementia New Brunswick Research Study, which evaluated a patient navigation service for persons with dementia and their caregivers. David's currently a member of the Canadian Consortium on Neurodegeneration and Aging Engagement of Persons with Lived Experience in Dementia Advisory Group and is involved in various dementia health research studies. And with that, I will let you take it away.
Perfect. Are you able to see my screen? I'm just gonna assume no answer is a good answer. Okay. Thank you, Bryan, for the introduction. My name is Joy, and this presentation from David and I is based on my master's research project, which we've been working on now for the last 2 years or so, and we're in the final sort of stages of wrapping up. So the project focused primarily on developing a improved home reminder system for people living with dementia. And the goal was to bring together my research background as well as interviews with caregivers and people living with dementia, as well as consistent collaboration with lived experience advisors. So today, we're not going to focus too much on the technical details of the system and the AI that we've been working with. Instead, we wanted to take this chance to talk about the value of involving lived experience advisors consistently and from the beginning of a research project. So I'll start by sharing sort of what changed my perspective as a researcher through working with lived experience advisors. And then David will speak on his experience as a lived experience advisor with this project. So my background is in AI, and when I started this master's project, I was very focused on the technical problems. I found that to be very cool and novel. So initially, my project was focused on if we could use AI to detect meaningful patterns in reminder use data, because that had never been done before. And I still think that it's a very important question, but early on, I realized that the algorithms that we're making don't mean much if the overall system isn't something that people would want to use. So we wouldn't be able to get any data if no one ever actually used it, and you need the data to run any sort of AI model. So especially in dementia care, where the goal for us is not to add another complicated tool for caregivers to use. Our goal is to sort of reduce stress and uncertainty and workload. If we create a system that requires caregivers to constantly interpret confusing data or troubleshoot the technology, manage extra work, then it would be considered failing, even if the sort of AI models behind the scenes perform with really high accuracy. So my research question actually shifted quite significantly from the beginning of my project until now, and went from can we use AI to detect these patterns to would detecting these patterns actually make sense in the caregiver's perspective, and are we making sure the technology fits well into their lived experience? So part of this realization came from working with 3 lived experience advisors, including David, who will speak soon, as well as Kelly Beaton and Myrna Norman. So some of the questions that they helped me realize needed to change was, instead of only asking what the system could detect, we had to ask about what caregivers would actually find useful. They helped challenge a lot of my assumptions. So for example, we're looking to see if missed reminders can represent any sort of change in the person's behavior over time. But what we learned is that the change in their response doesn't automatically mean whether a task was completed or not. And that reminder data isn't a perfect record of what's going on in the house. There's so many other confounding variables, such as if the person was just on vacation or if there's someone else tapping on the reminder system on their behalf. So this significantly changed how we interpreted the data, which downstream impacts how the AI systems should be designed. And for me, this is sort of the biggest shift where lived experience didn't just improve the design of the system, but also change what counted as a sort of good research question. And this quick interface change is a little example, a visual example of how lived experience advisors like David have impacted my research. So on the left, you see this was the sort of first iteration of what the reminder system looked like, and the right is the second. I don't think I need to explain too much why the one on the right looks a lot better. But just for the sake of time, I'll move on and let David speak about what the collaboration looked like from his side and specific ways that lived experience advisors have shaped this project from the beginning. David, I think you're muted.
Okay. This is my introduction. Thank you, Joy. Along with my colleagues Kelly Beaton and Myrna Norman, we served as persons with lived experience of dementia advisors for the Reminder System project. Given our extensive experiences of living with dementia, as well as family caregivers of parents with dementia, we were able to bring to the project the realities that we, as well as many of our friends, experienced through our journeys with dementia. Our role was not to serve as after-the-fact participants, but instead as regular collaborative partners throughout the course of the project, starting before data collection and continuing to presentations such as today. In partnership with Joylie, we were able to influence the design by pointing out that there could be difficulties working with the technology given a possible lack of dexterity, some may have pressing the buttons, as well as potential confusion with having too many buttons. We also advised to make the text on the buttons larger and use terminology that was clear and concise. For example, start instead of log in. We also felt that it could be intimidating getting to know how to work with a tablet in general. However, this might represent a great opportunity to have a younger member of the family, when possible, visit the home in order to be on site to help when the system is first starting to be used. Given the customizability of the system, we suggested it would be a great idea if the care partner could record both the reminder and follow-up questions in their own voice. We felt that this could be both helpful with early adoption, as well as continuing use of the system on a regular basis. We were also able to review with Joy her initial interview questions for participants so as to hopefully make these meetings not only more productive, but also efficient by not getting tied up with initial misconceptions. For example, we felt the privacy issues could very well be at the forefront for both the care partner as well as the person with dementia. In other words, the interviewer should be prepared to provide clear, non-technical answers as to how the data will be stored and for how long, as well as who will ultimately have access to it. We also felt there need to be specific answers as to who, how, and when future support would be provided should there be any technical questions. As this is a home-based system, we felt that participants would want to know if the system could be either turned off and or updated when the person with dementia is away from home and not present to respond to reminder questions. So with this particular question in mind, those perceived lack of responses could be alarming to the care partner, who may not necessarily know that the person with dementia had made an arrangement to be away from home that day. During our regular monthly meetings with Joy, we concluded that it would be very important to try and make sure the participants were aware that the responses to the questions from the reminder system should be made by the person with dementia and not by anyone else who happened to be visiting the home at the time. We felt that this would help to not only make responding a routine by the person with dementia, but to also show that responses were relevant to how the person with dementia was actually feeling at that time. These are just a few of the examples of how we, as persons with lived experience of dementia, felt that we were not only listened to in a meaningful, collaborative way on a regular basis, but also able to contribute in a value-added way to the development of the reminder system project. We were also very appreciative that through Joy's leadership, persons with lived experience of dementia team members whose backgrounds were not in any way associated with the healthcare, social care, and long-term care systems could also have a meaningful impact on dementia health research. Research projects that have persons with lived experience of dementia advisors as regular collaborative team members are better able to provide a project that resonates with those persons they're trying to help, because they'll then see a project that is relatable to the reality that they're living with today. I'd like to thank all of my colleagues with the Reminder System, as well as the Age Well EPIC Conference, for the opportunity to present today. Thank you.
Thanks, David and Joy, for such a terrific presentation. It seems like such awesome work that you both are doing. Just a reminder, if you want to leave your questions in the Q&A box, I'll be moderating that for questions, but we do have one question here. So this is from Shmuel, and they said, according to your opinion, do persons with dementia need lived experience advisors for better and easier integration into society? So, yeah.
I'm sorry. I just could you repeat that question again?
Yes, for sure. Yes. I think the question is whether it'd be helpful for persons who are living with dementia to have some sort of lived experience advisor so they could better integrate into society as well.
Yes, I think so. I also think that's true for research studies and research projects as well, to have both persons living with the disease, obviously, as well as caregivers for them to participate and help, hopefully, to ensure that the reality is part of the outcome of their study.
Great. And then maybe we'll fit one more question. So here, this is in the chat. Why do you think some researchers resist real inclusion of older adults with dementia? And how can that hesitation be overcome?
Oh, great question. I think really the only way to do that is just to start talking with one another and to try and onboard that person early on in the project, and just use a continuing dialogue to kind of make everyone feel comfortable, and to recognize that we're all human, and we do have a voice, and I feel we can really be value added to whatever work researchers are taking on.
I will quickly maybe add on to that. I think for researchers, at least for me, a master's degree is quite short. So one of the barriers is just the timeline. It's very hard to do extra ethics approval or to take that additional time to reach out to different organizations to get these sort of lived experience advisors on board. But what I found, which is we actually think we have a paper in a different conference that mentions this, but the time that we save once we include lived experience advisors is so worth it because it saved me a lot of sort of side quests that I didn't need to do, that a lot of sort of failures that they caught right off the bat. So I think if it's advertised more in this way, if it's a time saver for researchers with a bit of initial time investment, I think that would help make this sort of framework more popular.
Totally. Great answers. Thank you. Yeah, it's just like so important to kind of like foster those relationships, and like the feedback from the individuals with lived experience is so valuable. So thank you for such a terrific talk. Okay, I will keep things going. So next I'm going to introduce Zoe Gilson and Sam Liu. So Zoe Gilson is a doctoral student in clinical neuropsychology at the University of Victoria, and her research focuses on modifiable risk factors for dementia. So things like nutrition, physical activity, stress management, and so on. And also how to promote behavior change for dementia prevention as well. Zoe's work integrates digital tools such as mobile health applications with structured interventions for older adults at risk for dementia to create accessible and scalable public health tools. And additionally, her research explores how multi-domain lifestyle factors impact brain health and cognitive aging, health equity for rural and remote aging populations, and how chronic conditions interact with cognition over time. I'd also like to introduce Sam Liu, who's a co-founder and CEO of Pathverse, which is a digital health research platform that supports decentralized, hybrid, and mobile health studies. Pathverse helps research teams to design, deploy, and manage digital interventions, ecological momentary assessments, remote monitoring, and multi-site studies without extensive software development capacity. He's also an associate professor and director of the Digital Health Lab at the University of Victoria, where his research focuses on digital health, physical activity, family health, and the psychosocial factors that shape health behaviors. And his work bridges research, technology, and practice through user-centered design, community partnership, and implementation in real-world settings. So without further ado, I'll turn it over to you both.
Thank you, Bryan, for the introduction. Just share my screen. All right. Yeah, Sam and I are really looking forward to talking to you all about our Age Well funded project, patient and industry partner collaboration in the development and optimization of MindMover. I'll give a brief background. I know you've already seen this this figure from the Lancet Commission from Bryan, which was really great. I'm just going to go over a little bit of that again. So dementia is one of the leading causes of disability worldwide. There's 50 million people currently living with dementia globally, and this number is expected to double by 2050. Research has shown that nearly 50% of dementia cases could be delayed or prevented by targeting modifiable risk factors, and these include proper nutrition, physical activity, stress management, sleep hygiene, and much more. Subjective cognitive decline, or SCD, which is where individuals report subtle changes in their cognition but show normal performance on objective tests, has been shown to be an early predictor of future dementia. And this presents a critical window for preventative intervention for older adults that are at identified risk. Psychoeducation, where information is presented to patients about an illness and its treatment, is a highly effective tool in clinical practice to promote engagement in preventative or treatment behaviors. And a particularly helpful and effective tool to facilitate behavior change interventions using psychoeducation are mobile health or mHealth apps, which are mobile apps that present and store health information. So using this information and background, we designed an mHealth intervention using psychoeducation to promote engagement in dementia risk reducing behaviors called MindMover. And you have an example there on your screen of some of the cards that we have in there. So MindMover presents 6 educational modules. There's diet, physical activity, social connections, intellectual activities, stress management, and sleep over 6 weeks, with 1 module per week. And it includes text, videos, and other multimedia content, as well as quizzes, surveys for behavior tracking, and it's presented through Pathverse, which we'll hear about in a little bit from Sam. We have had previous pilot and feasibility studies that were evaluating the intervention, and they showed high acceptability and feasibility, but participants' engagement with the actual intervention was lower than we were hoping it would be. So for this project, we built on those previous studies to improve MindMover. MindMover has been developed and tested using the orbit model, which is an iterative process, an approach to intervention following from a significant clinical question. So for us, that's how can we improve engagement in these dementia risk reducing behaviors, moving to designing and refining an intervention, pilot and feasibility trials, efficacy trials, and finally effectiveness trials. Throughout the phases of testing, there's a constant feedback loop of changes to be made to optimize that intervention. So it's not really a linear, but more of a iterative process. Our objectives for this portion of the project, where we were returning to the design and refine phase after those pilot and feasibility trials, were to integrate mobile cognitive tasks into MindMover and make adjustments based on user feedback, as well as gain feedback and make adjustments for content, usability, and user engagement. To achieve these objectives, we recruited an advisory group of older adults with dementia, mild cognitive impairment, or SCD, as well as caregivers, and that resulted in us having an 8-person group with 4 dyads, which were, they were all married couples, 1 person with dementia, and 1 person who was their spouse who also provided care. We held 3 meetings over Zoom where the group participated in a facilitated discussion about what works and what doesn't work with the intervention after having some time to explore it, as well as tested the mobile cognitive tasks that we had put in there. We then worked with developers from Pathverse to integrate the advisory group feedback into the app, and we would bring those changes back to the next meeting for the group to discuss and continue that iterative process of feedback. I'm going to hand it over now for a minute to Sam to give some more background on Pathverse, as they were our industry partner for this project.
Great, thank you so much, Zoe. Yeah, so we developed Pathverse as a research tool to help researchers to build any types of mobile apps without software coding. So the platform allowed researchers to construct an app in a web platform, as you can see on the screen here. And then researchers can pick and choose the types of features the participants would like. For example, they could pick lessons, as Zoe described, where we can deliver psychoeducation programs, but we can also deliver other types of, include other types of features such as goal setting, self-monitoring, and researchers can really kind of pick and choose the features they want and A/B test it. Next slide. Oh, I think we're just a little lag there.
It's just frozen a little bit, but it is going.
Yeah, okay. Yeah, so so we developed this out of our research lab, and the whole idea of this platform is to help researchers so that it'll be easier for them to develop the various different types of apps and really decrease the resources required, but also improve the speed. And it's been shown to be very useful when we co-design the intervention with participants. So in this, when we're building these apps, you can see that we can set various different logics. We can increase different, we can incorporate various different goal setting features. We can customize the multimedia content and then incorporate surveys and get very detailed usage data. And then a thing, I think a feature of the app is very helpful is that we can also map onto the various behavior change techniques used in the app. So for those of you in behavior science research, this is very important so that we can know the exact ingredients or the components that we're using in the app to help individuals change their behaviors. So I'll leave it at that, and so we'll go back to Zoe. Over to you.
Great. Thank you, Sam. All right. So, after learning a little bit about Pathverse, I'll move us back to the results of those advisory groups. So, we received a lot of feedback from our group. This was really helpful to allow us to make changes that were relevant to our target users. For usability, members of the group noted that the app was initially difficult for them to navigate and they wanted clearer instructions. They also noted that the content cards, so the example that you saw earlier, that they were a bit too text heavy and they would prefer to either have that text read out to them or to have more images so that they were relying less on reading. Also, some of the members stated that they don't always use their phone for something like this and they'd be more inclined to use it on like a laptop computer. So from this feedback, our developers worked hard and they added lots of additional navigation instructions within the app, as well as a brief navigation tutorial when you were first opening the app that highlighted different areas and different buttons to be used. They revamped the user interface to improve organization and look. We added text-to-speech or like a screen reader option so that if someone would like to, they can press play on the card and that can be read out to them rather than having to read it. And then we also made the intervention accessible on a laptop or desktop computer. For content, members noted that the content was interesting, but they were unsure what was being done with those survey responses for behavior tracking. They wanted real-time feedback on their behavior engagement, and they also wanted the ability to connect with other users. So from here, we added prompts based on their survey responses. So if someone was logging their exercise and they were under the recommended guidelines for exercise, a prompt with an exercise suggestion would pop up after that response. And then a community forum was also opened in the app as well, so they could communicate with each other. We could also add a topic for them to be discussing in that forum. And then for the mobile cognitive tasks, members found them interesting, but they found the instructions and the feedback they received afterwards a little bit confusing. So with that information, we restructured those instructions, we brought the reading level down, and then adjusted that for the feedback as well to be in more lay language. So overall, what we saw from our sessions with the advisory group were that MindMover has strong and relevant content, but the usability of the app was where improvement was needed, and we were able to make adjustments to address this. With these adjustments, a fully digital adaptive platform for dementia prevention offers a wide reach at a relatively low cost for older adults. Additionally, this type of intervention is particularly relevant for older adults in rural and remote areas, where compared to cities, access to in-person dementia prevention or intervention programs are limited. So as we continue with MindMover, we will also continue our patient partner work. Many of the members of the group are interested in continued participation, and this has provided us with such valuable feedback, so we're really thankful for that. We're also moving through to the efficacy trial phase of the Orbit model to scale up to a randomized control trial, which will give us information on how well we can promote significant behavior change using MindMover. So thank you, everyone. We wanted to acknowledge the rest of our team, Jonathan Rush, Theoni Patterson, Henry Law, Jamie Knight, and Ritu Randhawa, for all of their hard work, as well as acknowledge our funders, Michael Smith, Health Research BC, and Agewell for supporting this project. And we also want to acknowledge our patient partners and Pathverse for their collaboration on this project. So thank you.
Thanks, Zoe and Sam, for such a great presentation. It's so cool to see that work. I don't see any questions in the Q&A right now, but I guess I could ask a question. I was just really curious about kind of like that remote and rural kind of representation in kind of like the patient groups. Were you able to get involvement or representation from folks who might be living in rural and remote communities? And how did you find that, if so?
Yeah, that's a great question. We were hoping to have that. We did have a couple that were up in Prince George in BC, but we didn't have the type of representation that we were really hoping for to get some of those rural and remote people. One of our targets for our scale up to a randomized control trial is to do targeted recruitment for individuals in rural and remote areas so that we can really get both feedback from them, but also real-time data on how they're able to use it and if it's effective.
Awesome. Okay, so maybe I'll let folks percolate on like all the presentations, and then we can all come back together for like the final chair for all the final Q&A session for all the questions all together. But I will thank you both again, and then I will introduce Annika Moon for the last presentation for today. Last but certainly not least, we have Annika Moon, who is the co-founder and COO of Living Safe. This is a Montreal-based startup developing a privacy-first monitoring and fall management system for senior care environments. She focuses on the implementation and change management, working closely with care teams to integrate their technology into daily practice and improve visibility, response, and safety in senior care settings. And she's also a recipient of AgeWell's 2022 Emerging Entrepreneur Award, which is very exciting as well. So I will turn it over to you for the Moving the Dial presentation. Thanks, Annika.
Thank you, Brian, for the introduction. I will share my screen. Here we go. Hi, everyone. Thank you so much, AgeWell, for the invitation, opportunity to present. Today, I'm very happy to have the opportunity to share with you our passive monitoring and fall management solution and what we're doing at Living Safe, how deploying the technology specifically inside dementia care environments has changed the way we think about safety, visibility, and care. So I'd like to begin with a scenario that happens frequently in senior care establishments, long-term care homes, retirement homes. It's 3 a.m. An 82-year-old resident with moderate dementia gets out of bed during the night. She goes to the bathroom and she falls. The morning shift finds her on the floor 2 to 3 hours later. She can't tell anyone how long she's been there or what happened. Unfortunately, this type of situation is not only very common, but it's what happened to my co-founder David's grandmother some years ago. Except in her case, she waited 12 hours on the floor before being found and suffered extreme consequences because of it. So as you can imagine, this experience is a big part of why Living Safe exists today. And before diving deeper into what we do specifically, and in line with today's challenge area, I think it's important to recognize how different dementia care environments and patients really are when it comes to fall specifically. In Canada, 2 in 3 long-term care residents have a diagnosis of dementia. And there's 3 realities that are especially important here. The first is that falls in dementia care are often tied to things like wandering, nighttime disorientation, restlessness, or agitation. And this can make them much more unpredictable and difficult to anticipate. And research also shows that individuals living with cognitive impairment experience falls significantly more frequently than older adults without cognitive decline. Second, when an incident does happen, residents with cognitive difficulties are often unable to explain or remember what happened afterwards, leaving care staff with little to work with, and it can make it difficult to understand what led up to an incident, how long someone may have been on the ground, and whether similar situations are happening repeatedly. Sometimes the resident is able to get back up on their own, but unable to communicate that an incident happened. And finally, many traditional approaches to fall detection, such as wearables, rely heavily on what I'll call here active participation, meaning, of course, to be effective, it needs to be worn at all times, or at least at the most crucial times, which usually will be in the bathroom or shower or at nighttime. David's grandmother, for example, had a fall detection pendant that was provided by the family that unfortunately she was not wearing when she fell. So that consistency is especially difficult in environments affected by memory loss, confusion, or behavioral symptoms as well. So even though Living Safe was designed more broadly for senior care environments in general, these realities did have a major influence on how we developed our solution as well. So that's where Lisa comes in. Lisa is a passive privacy-first sensing system that uses wall-mounted radar sensors to create continuous visibility inside a senior's living environment. When we started building, 2 things were important to us. The first was no wearables for the reasons I just mentioned. And second, privacy first. As a non-wearable, we needed to be able to monitor full units and to include coverage of spaces like the bathroom, where many falls happen and where cameras or microphones simply fall short. for families and residents due to privacy concerns, and maybe especially sensitive in dementia care where consent and privacy become much more complex. So what you see on the screen, the little animation, is an anonymous point cloud representation of movement inside the room, basically of the person moving and falling. And originally, the goal for Living Safe was relatively simple, to detect falls and help avoid situations like what happened to David's grandmother. But once we started deploying in real care environments and working closely with retirement home care teams, operators through co-development initiatives and pilot projects, those partnerships pushed us to look at the data differently. And we began realizing that knowing that something happened is important, but it's not the whole problem, and it's just the beginning. And in dementia care especially, the deeper challenge is often reducing uncertainty around the incidents, around what happened, when it happened, how long someone was on the ground, what was happening beforehand. So ultimately, the richer signal was in the patterns and indicators the system could identify leading up to or surrounding the incident. So that's where Lisa evolved beyond fall detection alone. And we co-created and added features like additional alerts for bed exits and wandering. These are particularly useful when there's individuals that are particularly vulnerable to falling as soon as they get out of bed. And we mostly see these alerts used at nighttime when there's reduced staff. And more analytical additions as well of habit behavior pattern analysis, where indicators of decline may be telling over time, as well as specific incident analysis where the fall can be reviewed and our system can provide more context on how the person fell. So our goal here became to provide a tool that helps support teams working towards prevention, not only the detection of the incident. In terms of how the information is communicated, our strategy is really to work towards supporting multiple integration pathways so that the system can adapt to different care environments. So that includes partnerships with nurse call systems, mobile notifications, our own dashboard, and integrating in existing care platforms already used by staff. And what we want to do here is to make meaningful information accessible inside the workflows already used in care environments in order to support adoption and usability. So to close, I think this experience over the past few years has taught us, and what it keeps teaching us as we're moving forward, is that bringing innovation into care environments, that moving the dial is often much more human and operational than just about the technology and innovation itself. And through that process, three things consistently stood out to us that I thought would be worth sharing as our takeaways. The first is that preparation and timing is crucial. For a successful implementation, it requires investment and effort from all stakeholders, whether it's the technology provider and innovation, the care teams, the operators, or leadership inside the environment itself. Engagement matters so much, and to get that, everyone needs to be ready in both in timing and in operational capacity. Second, collaboration. Working closely with care teams and partners continuously reshape the system in ways we never would have anticipated in the beginning, as the evolution of our features I mentioned to you. But it also taught us something harder, that the many stakeholders involved have different realities and priorities that need to be taken into consideration, and an alignment between them takes real ongoing work together. Third, adaptability. Real care environments are unpredictable and complex, and routines change, priorities shift. No two deployments seem to look the same. So being able to listen, adjust, and stay responsive as a startup and innovator matters as much as the original plan. And the meaningful information we're trying to provide only matters if it reaches people in the right way and fits well into their realities. Because at the end of the day, improving care environments isn't just about building better technology, it's about building solutions people can realistically adopt, trust, and integrate into daily care. So that wraps it up for me. Thank you very much. I'll be happy to answer any questions, and don't hesitate to connect with us directly as well.
Thanks, Annika, for a great presentation. Thank you so much. I have one question for you over here. So, Anamika said that this is a great solution and whether this has been used in home care settings before and what kind of implementation challenge did you face initially?
Yeah, great question. Definitely, as my presentation highlighted, our initial strategy was to really go in establishments, but our objective is absolutely to support aging in place and get the solution out in people's homes that want to have it there. We have started some initiatives with home care providers that can offer our solution within the range of services as a starting point. But in the future, we hope to go even further than that. And in terms of implementation challenges, um, in establishments, definitely, I don't think that resistance is the right word, but I think there's definitely caution about innovation and new technologies like this. And it takes time to earn trust and just to also show that there's people behind this tech and it's not just AI and big techy things, but that, to help people understand that we're really a tool that's trying to support them and help them and not replace them either, right?
Thanks, Annika. We have a few other questions here. So one is thanks for the presentation. Your solution is really great and extremely important. How do you deal with false positives and false negatives? Before we move on, I'll also say that if you want to ask questions for anyone on the panel, we could do so with this general Q&A as well. And I'll monitor the question box for that, but I'll turn it over to Annika to answer that.
Absolutely. I think going in, false positives was a big concern. It was something that we immediately put a lot of importance on. And so that's one of the main things technologically we worked on before going in. And then also going in because it's one thing to have a good false positive rate in lab. But then it's another thing when you come into the real environment, and we were very lucky to have co-development partners that allowed us to really put a lot of systems out there, and to be able to then have our technology learn from those environments without necessarily bothering staff and starting in phases of at first without sending alerts so that our technology learns the environment and then making sure that we're at a good false positive rate.
Maybe this touches upon like another question that's in the chat as well, but talking about like the environmental factors that might have affected things like data transmission and sensitivity. Did you run into anything like that?
Yes, definitely. Once you go in the real environment, you see a lot of things. You see how cleaning, when the cleaning staff comes in, is picking up things under the bed, things like that, can definitely affect systems like this while in development. Um, and that's why, again, I would repeat a bit the same thing that I answered in terms of false positives, that we were lucky to be able to work through that with good partners.
Okay, Sam here asked a great question that I was also thinking about as well. But this is for all the panelists, so maybe we can give you a bit of a break, Annika, first. But everyone today really underlined that age tech is about the people that are involved, not just the technology. So maybe I could go around and ask all the presenters about some of the greatest opportunities and risks in the development and implementation of technologies that you see in supporting people living with dementia and also their care partners as well.
Well, I'll start off if that's okay. I think one of the greatest benefits is that if we can have people living with the disease be able to stay in their own home safely, I think that goal in itself overcomes a lot of hesitancy that people might have with tech. In other words, they're going to power through and figure out a way to make it work. if the ultimate goal is that, yes, I can stay at home and I won't have to go to long-term care. And so in all these things, there's the dyad, right? So the multiplier effect is that for the care partner, they can have a little more comfort level with regards to that person and their care being safe at home. So I look forward to the last presenter to be able to make that a home-based possibility. But I also want to thank Anika for overcoming the issues with not having to wear wearables. I know that's can be a real problem, and so yeah. Anyway, I'm just sorry I talked too much, as Joy would probably tell you, but I'm excited to be part of this. And as the gray hair here, I really am honored to be working with all of you. I'm enthused by your work and the dedication that you put into it. And so I'm hopeful that we'll see improvement with regards to where seniors can age in their final years.
I'm sure that I speak for everyone that we really value your perspectives, and the work wouldn't be done without kind of like voices like yours, David. So maybe I'll ask some of the other presenters if you wanted to touch upon any of the opportunities or risks that you see in developing these technologies for individuals with dementia and their care partners.
I can jump in. I think I would echo a lot of what David said. I think there's just so much benefit to actually having, like for us with our mobile health intervention, having the end users involved much earlier. The amount of changes that we were able to make that we weren't even thinking of, or we were thinking that we had a solution, but that actually wasn't what was going to work for the individuals who we want to actually be using the technology. It makes such a difference to have that perspective in there. And I know we heard that from our patient partners as well, that like being included in this process meant so much to them too. And they know that they can provide so much feedback. Yeah, I think generally just a huge benefit.
I think I'll jump in then. I think I echo what Zoe said. The co-design phase is important. I think one of the challenges I think I can talk about is thinking about the implementation. So a lot of times, we often think about implementation after kind of the effectiveness trial. I think a lot of researcher behavior scientists think about that. I think it's really important to involve perhaps implementation scientists or even have an implementation frame lens right from the beginning of the co-design to think about some of the challenges, especially when it comes to cost, I think for some of these technologies and how that will be perceived and how does that work with the existing infrastructure at a home or a care home. So those are the challenges I think we should be thinking about as well.
Annika, Joy, did you want to jump in with anything else as well? Or?
Sure. I mean, I think that Zoe, David, and Sam summed it up quite well, and it echoes back a little bit to our learnings as well as we started implementing and the opportunities. I feel like there's many ways that technology can come in and help in these types of environments, and the risks are really to, the technology is only as good as, or the innovation is only as good as being able to be used in reality. And I think I have heard statistics on it, but that it is very frequent that good technologies fail at the implementation, right? So.
All right, I think we're running short on time, but there were so many great nuggets of uh, uh, advice and like nuggets of wisdom, sorry, like all throughout this presentation. And I think some of the take homes here that I'm really drawing on are kind of like centering like the people involved in all the research, and also inserting a lot of like those implementation factors for this as well. I think is super important. But with that, I want to give a huge kind of thank you to all of the presenters again. Thank you for such wonderful talks and presentations. It was so lovely to hear it all. And thank everyone in the audience for listening today. It was a pleasure to have you all and be so engaged in like the Q&A as well. And be sure to check out all of the other terrific talks during the other challenge areas in EPIC this week as well. And with that, thank you very much and have a great rest of your day.